It's a pleasure to be here. Thanks for inviting me. And what I'll try to do for the next few minutes is I'll try to give you the more. Oh, thanks for that. Makes things easier. So I'll try to give you some of the evidence that come from research and interventions and the literature that we know that we have covered in the Mental Health Foundation. And what we do in the foundation is we focus on public health and population health. So we know, as Rachel has very clearly said, there are things that work for some people and don't work for others. It's the same for treatments, it's the same for all kinds of interventions, nutrition, exercise. It's good to try as many things as possible because there is a combination that would eventually work for a person, hopefully. And the way that we work in the foundation is we essentially we do research and policy and practice in one, and then we try to transfer these messages into the services, into the community, working very closely with both the experts by experience and the experts by background. So it's that co-production element into all of our activities that makes the difference. And when I talk about public health and when I talk about taking a public health approach, what I mean is essentially looking at the big circle in the World Health Organization framework, which is prevention. And prevention, in our sense of the term, covers a few different things, which I will outline. But I want to explain why prevention. And I'm not. I think it will become clear once we cover a few of these things. We do have an increase in mental health problems in children and young people. We have the adult psychiatric morbidity survey coming out every 7 years. It came out late last year. It showed for the first time since it has been circulating a very strong increase in mental illness among young girls and young women. So this is the major trend we have seen over the past few decades. All the other trends are much smaller, but we know now that young women have, there's a very strong trend there for increase in mental illness. Very important to note. 50% of all adult mental health problems have already been established in childhood, 75% by early adulthood. So the earlier we get in there, the earlier we tackle that stigma and we encourage people to talk about their problems and to seek for help, the much more likely we are to succeed. And I think people are well aware that adverse childhood experiences can have a very detrimental effect to people's mental health. And if I take an average classroom in the UK of 30 students, about half maybe would have witnessed, or maybe a third or half would have witnessed their parents either separate or getting a divorce or having a toxic relationship in the house. One would have experienced the death of a parent or occasionally the death of a sibling, and about 6 or 7 would have been bullied. This can be either in school or in their neighborhood or online. And this is increasing, obviously. The online bullying is obviously increasing as years go by. And you won't be surprised, I think you're the kind of audience that wouldn't be surprised to see this slide, so unless we have any cyborgs in the room, hopefully everyone's human, yes. So everyone has mental health. This is what mental health is. It's a state for the individual, and it's an asset for the community. So everyone has mental health, and a number of things around you affect your mental health and can impact on your mental health. So when we talk about mental health and when we look at individuals, and then when we take these individuals and group them based on different characteristics, we need to look across their life course. So we need to look from early adulthood, from early life, your bonding with your parents, your experiences in school, then university or first job, being unemployed, all the experiences adverse experiences that you may experience as an adult, being a parent, and eventually being in later life. And we have a lot of interesting statistics. I don't want to give you all the statistics to overwhelm you with numbers and data, but there are a few very interesting things like lost employment opportunity costs £23 billion in the UK. So people with mental illness who are not in employment, £23 billion. People with mental illness or borderline mental illness, which is not diagnosed but are at risk, who are at work, contribute over 200 billion pounds to the economy. So the people out there who are not convinced by the personal case studies and the stories or by the health impact, I think they should be convinced by a number like that. And there are people who are convinced by this kind of figures. So this is what I mean when I talk about prevention. There are three types of prevention. Prevention is, there is primary prevention, which is the universal approaches, and it means that we want to prevent people from getting ill in the first place. There's secondary prevention, which are the selected approaches. Secondary prevention means that we would target the ones that are at most risk, and we would work with them to help essentially keeping them healthy as much as possible. Tertiary prevention, what we call indicated. This is working with people who are already diagnosed with a mental illness and trying to keeping them out of services essentially as long as possible, trying to make them functional in their lives and they can thrive in their lives. And we do have an approach in which we believe that you can thrive in your life even if you have a mental illness. And examples like what Rachel has given is excellent, because I think there's a key aspect in mental illness in which when you receive a diagnosis, this becomes your identity. So you become your diagnosis. So what is important to work with the people is to find a diagnosis that is not, find an identity that is not your diagnosis. So you're not the bipolar, you're not the schizophrenic, you are a parent, you are a friend, you are a neighbor, you are someone in your workplace, and you have a number of other roles that are equally important. So what I'll start covering now, a bit about the evidence. We need to look at mental health across the population, across the community, and there are four aspects of that. We need to look into policies, settings, services, and impact measures. I'll explain what this is. Mental health in all policies means that we will work across all different policies that may impact on your mental health. It's not just health, it's not just Department of Health, it's education, it's criminal justice, it's employment, so it's a number of different things. And the way that policy works, obviously, is we take some time, we look at the evidence, we work, and we wait for the window of opportunity to lobby for new policies and to try to drive new policies forward. There's a very good window now for mental health, and there will be for the next 5 or 6 years in the UK and globally, before politicians find something else to be interested in. But for now, I think those of us working in mental health feel that interest and see that interest. Hopefully it translates to money. It doesn't always, but hopefully it slowly translates into more money. Mental health in all settings, again, it means that we need to look into mental health not just when you are in service, not just when you are in hospital, but also when you are in your school or your workplace, or even in your house, working with your family and your friends and your connections. This is the circle of stigma. Essentially, how the circle of attitude works. You have an attitude. Stigma is an attitude. When it leads to discrimination, that is the action. So stigma leads to discrimination, which could lead then to social inclusion. The more you stigmatize mental illness, the more you discriminate against people with mental illness, the more you exclude them, and then stigma becomes a vicious circle, which is very difficult to get out of. And I'm glad that Rachel touched on stigma. And stigma obviously is not just on mental illness, it's stigma on many different things: ethnic minorities, cultural minorities, learning disabilities, a number of different aspects. So the people who are excluded are also the highest risk of developing a mental illness. People who are discriminated against, highest risk of developing a mental illness. So it's really 2 or 3 circles intertwined, leading from stigma, from our attitudes, causing mental illness to a number of different people. And I was very encouraged that Raymond talked about the type of services that Bridge offers, because traditionally services, essentially, if I explain this graph a little better, if you see the horizontal line, we have people who would be diagnosed with an illness here, people who would not have a diagnosis here, and what traditionally services try to do is to move people from being ill to being what is perceived from services as healthy. But there's more to you than the illness. So we have people who can thrive, who can flourish in their life, and we have people who are really languishing, people who are struggling. So we need to do a bit more vertical movement. So we need to move, not just move people on the horizontal line, but also a bit on the vertical line. So you can have a diagnosis and still thrive, flourish in your life. And the fourth element is in all impact measures, which is starting to be creative, starting to be clever and intelligent with the data that are out there. So we know, when we look at the evidence, we know what works, and we know what can be implemented. This is an example of perinatal mental health services delivered across the UK. Red are the places where perinatal mental health services are not up to scratch, or they don't have enough money. So a quick run through the evidence across the life course. In early life, we know parents, we would start with parents, we start working with parents. Bonding in early life is very important. Relationships between parents. I'm very happy to give all the evidence, all the publications, maybe in an email, and I'll include my email address in the final slide. So family solutions, positive couple relationships, these are things that we know improve the child's mental health. In school, this is the whole school approach. A whole school approach means that you don't only work with children, but you also work with the teachers. This is the next big group. So starting from parents, we would work then with teachers, but it's also staff development. It's also working with the parents and the carers, and the ethos and the environment, the whole culture in a school that is important to nurture good mental health. Going on to teenage years and early adults, peer-to-peer approaches, there is good evidence, and it's been, and we accumulate even more good evidence that young people value peer interventions. So the more we train young people to deliver interventions and awareness to their younger peers, the more we know that this will increase awareness. So, and it will increase, essentially, very importantly, it will enhance attitudes around stigma, discrimination, and bullying. In the workplace, again, a whole workplace approach. The third big group that we would work with is the line managers, the employers, the senior leaders in organizations, so that they can create a culture that values really the staff engagement, and really understands also the economic argument that we made, that you probably, if you make an environment that is a bit more flexible for your people, that it really values and can give a break and can really value a person even with mental illness, then you probably will have a much more flexible company and a much better results. In the community, the fifth group that we work with is the local leaders, people like faith leaders, people who deliver local courses. Again, they are very influential in their circles. So if we train them in mental health awareness, if we train them in mental health first aid, we do have very good evidence that they can make a big difference. We would co-produce approaches, so we would make approaches. This is the evidence. Co-production means that we make approaches that speak to the local communities, to the people who you are working with. There are lots of limitations to the evidence, so if you go away tonight and you start working on some of these, I'll be very pleased. We know that all these groups have high risk for mental illness, but we don't have these large-scale interventions that have shown promise. Areas that we would definitely work on in the next few years, like looked after children, poverty, transitions, and the next big challenge in mental health. Essentially, whenever you change a situation in your life, this makes a big difference on your mental health. So how can we prevent serious mental illness during a transition? And of course, going upstream in essentially developing all this work in mental health services and mental health prevention. So working what we call not just the interdisciplinary approaches, but the transdisciplinary approaches, which is working with the people who are experts by experience, so that we're not developing services and interventions and we're parachuting them in an area, but we tailor our approaches to the people that are at need for them. So that's pretty much it, including my email address. I'm happy to provide evidence-based papers and documents if this is your thing, if you want to read more. It was a bit of a whistle-stop tour of some of the evidence that we have, and I'm happy to take any questions.
Obviously, with the presence of social media now, you say that there's an increase in younger people being diagnosed with mental health. How do we as a community tackle that? Because it has such a presence now with younger people, even probably as young as 10, 11, having access to Twitter, Facebook, Snapchat, that it does genuinely bring into their lives bullying, issues around mental health that will be raised from a younger age. But how do we tackle that as a community?
No, it's a very good question, and it's something that really caught us off guard in mental health and public health, because I think 10 or 20 years ago, no one was expecting this whole area of bullying and discrimination reaching children without parents knowing, without teachers knowing. It's a new area that really caught us off guard. Makes you think, what will the next one be? I think on social media, we need to work with the children in the first instance. Not just on the behavior of the ones that are the bullies, because they are also as well, they are at high risk of later in life becoming mentally ill. But potentially what I would do is I would work with children perhaps in schools. I would encourage them on how can you make your social media accounts and environment mentally healthy or mindful. So And I think it's very legitimate. We do encourage people to block people who are messing with your mental health, to block people that are posting things that are not good for your mental health, to not engage in social media battles and discussions that are endless and ending up leading you into insomnia or being detrimental to your stress and your anxiety. So I think working with the children to help them understand why it is important to build a mentally healthy social media environment and how to do that is important. And I think in the same way as every one of us would like that. I want to go on Facebook and I don't want to see 100 posts about Trump, for example, but I want to see these positive stories and this positive messaging. I think the same way we need to work with children.
This is an ignorant question, but who are you? I don't mean you personally, but the foundation who funds you, how do you do your research, where's it published, and so on. I'm very ignorant about the organisation.
Sure. So the Mental Health Foundation is a national charity. We work across the UK, offices in all 4 countries. We've been around since the late 1940s. We do, essentially our role is to devise interventions, design them into being programs essentially of work within healthcare, within community, pilot them, test them, and then potentially embed them either into services or into the community. We publish our work academically. We publish our work on our website with reports, with accessible reports and guides, toolkits. We have one of the main goals is improving the mental health literacy of the public. So all our resources on our website, if you go on our website, all our resources are evidence-based. They have been either written or checked by researchers, by people who have who are experts by backgrounds, and we don't publish anything that we wouldn't have checked and double-checked, and we update our literature every year. So both on our website and academically, we do all our work is evidence-based. In terms of funding, we do receive funding from either the traditional funders like the Big Lottery Fund, Comic Relief, the funders that essentially fund interventions and delivery, the normal fundraising routes, and unfortunately not much government funding, but maybe we'll get there in the end.
I'd like to know how you're getting your work into schools. How are you proposing to do that?
Yes. I'll give an example of what we do now, which is one of the most promising approaches we've done in years, is a peer-to-peer education program. The first step for us is to identify a champion in each school, so a person who is interested in mental health, and you usually find them in PSHE or pastoral care. And then we go into the school and we train students who are 16, 17 years old to deliver mental health awareness sessions to students who are 11, 12 years old. 11 years old, based on the evidence, is the age where you can absorb the biggest amount of knowledge and still change your behavior. So by delivering these sessions, also obviously in a peer-to-peer setting, we maximize the change in attitudes and behavior and knowledge. It's not easy to work in schools. They have a lot of demands on their time, obviously, But I think the key for us is to find a champion in the school and show the evidence that what you do is worthwhile. Quite often we found that the teachers delivering the PSHE classes, they don't always have good materials or good or good evidence on what to deliver. So sometimes they do welcome these approaches and they do welcome to turn some of these sessions into these peer-to-peer sessions. So, yeah.
So have you got a strategy, though, for actually finding the right person? Because I was head of PSHE in a school and it just gets squeezed. It was one lesson, 1 hour a fortnight, and if anything else had to be done, PSHE got squeezed. And while among the students there's a great need and desire for this, it's having the will coming from that leadership to actually get it into schools, I think. And also, they don't want to open any cans of worms that they've then got to do something about.
Yes.
So best of luck.
Yeah, thank you. Thank you.
Hello, my name's Karen. I wanted to understand, in terms of your organisation supporting individuals that have mental health, but how do you support their families in terms of, if it is the breadwinner in the house and they have a mental health issue, how do you support that family financially? Because a lot of families find that when someone does have mental health issues, that their actual finances cannot be dealt with. So in terms of supporting families, in terms of lasting power of attorneys and how you can actually support them, because ultimately you've got an individual who needs medical help, but also when they actually are over their crisis, their financial situation is in a bad way, so that then puts them in a difficult situation.
Yeah. No, it's a good question. As a charity, we don't deliver the services and we don't necessarily work with individuals to improve their own lives or their family lives. We mostly take these population approaches. So we develop these interventions to improve essentially mental health of specific groups. The best evidence on what you're describing, I think, comes from peer support. So developing local peer support groups for people who share the same experiences. Defining who a peer is the first big question in peer support, because you want someone who has shared the same experience as you have, but also you might want someone who maybe if you're from an ethnic minority that is from your same comes from the same background, or if you're a migrant, maybe you want someone who has been a migrant. So defining who is a peer is very important. Creating the safe spaces to talk about mental health is very important, and then in these safe spaces you can work further to essentially set goals. There's a big science behind goal setting, but if you start setting these goals and supporting each other to achieve them, it could be things like looking after your bills and your taxes and your finances. It's very important, and I think the most compelling part of peer support is to get people who have essentially themselves overcome problems and are in recovery to support others who are in crisis, and this makes a huge difference. So I think, in response to your question, even if we don't do it individually, the best evidence that I know of come from these local peer support groups facilitated in safe spaces.
Okay, we're going to draw this to a close. We have a round of applause for Antonis. Thank you very much.